Hi everyone, we're here with Professor Nuala Lucas. Nuala is visiting all the way from the UK. She's President-elect of the Obstetric and Anesthetists Association, and she's just delivered a fantastic talk as part of our opening plenary session, the ANZCA 2023 ASM. Nuala, you've focused a little bit on about it's not a difficult airway, it's an airway made difficult. Can you tell us a little bit more about the key messages from your talk this morning?
Yeah, well, I think that there's a number of factors that conspire to affect anaesthetic performance in the obstetric general anaesthetic. Mostly it's an emergency setting. It's often been undertaken in the middle of the night by an anaesthetist who may be less experienced. I think equipment it might be variable on the lay ward. And I think it's a self-fulfilling prophecy. For years and years and years we've perpetuated, it's going to be more difficult, it's going to be more difficult. So that when that anaesthetist undertakes the intubation, instead of making subtle adjustments to direct laryngoscopy to get the tube in, as soon as the view is poor, they immediately bail out. And certainly that's been my experience in the failed intubations we've had in my unit, where once somebody else arrives, intubation has been achieved successfully. So I think we need to reframe the conversation as well as looking at strategies to try and reduce those factors that might affect an anaesthetist's performance.
And looking to the future, how do you see the landscape changing in terms of airway management in obstetric anaesthesia specifically?
Well, first, reframing the conversation, making people really understand, look, these intrinsically obstetric patients, pregnant women, pregnant people, I don't think inherently they are more difficult to intubate, and it's often very circumstantial. Of course, there are some situations where they may be, but let's stop setting up that story from the start. So changing the narrative, I think, is really important, and I think that confidence and that belief that it's not going to be so difficult. But of course, we do have to look at strategies, and I think obviously the most sensible ones are to use what technology's given us. I think videolaryngoscopy in obstetric patients. There are some questions to be answered about videolaryngoscopy, which device, and then which device is the best for obstetrics, but also recognising that some hospitals may choose one device, some hospitals may choose another device, and certainly for trainees who move between hospitals, that can be difficult. So we've got some questions to answer about videolaryngoscopy. And I think making better use of small strategies such as apneic oxygenation. It's not difficult, putting on some nasal cannula right from the start, just so you can keep the bulk flow of oxygen going during the apneic period and maintain oxygen saturations. So I think those would be my three top tips: change the narrative, use videolaryngoscopy, and apneic oxygenation.
I really liked when you talked about how we can change the narrative in terms of how we frame it with our trainees.
Yeah.
What are some strategies that we can help to improve our trainees' confidence when they are feeling stressed when they've been encountering what is a difficult situation, often in the middle of the night?
Yeah. Well, I think this is a very good question. I think this very heavily relates to the human factors element of things, and I would urge everyone to take a look at the recently published human factors guidelines, recently published in Anesthesia, that provide lots of really solid advice and recommendations about how you can mitigate those human factors. And an obvious one with trainees is just to demystify it. Practice airway management strategies in a simulated setting, so that if you do find yourself in the dreadful scenario of having to do front of neck access or something like that, it won't be the first time you do it. So practice outside of obstetric theatres and demystify it, and check out the human factors guidelines.
Great, thank you. What did you think of the other speakers, Curtis Nichols and Edith Matchop's talks?
I do obstetrics. I do other stuff as well, vascular urology. But I love hearing from colleagues about what's going on in their discipline, their areas of expertise. For me, Edith's talk using the marginal gains, just what can we tweak to try and reduce the incidence of delirium. And Curtis Nichols' talks was very entertaining. It's not an area of medicine that I have much involvement with, but it's great to hear things outside the confines of your clinical practice, and I just thought it was a very entertaining talk.
Agreed, very entertaining.